Good morning, friends. Today is Wednesday, early morning, and so I've been working a little bit. That's why a little late. Um, Today I'll be resuming my talk on this one. Bleeding disorders of blood in elderly. I done a part earlier, first part, in which I talked about anemia and myelodysplastic syndrome, and the last one. Today, a few topics are there. This is going to be slightly bigger. This is this one myeloproliferative disorders, myeloproliferative disorders, then multiple myeloma, another bone marrow condition, and then lymphoma. By no means a lymph node condition only, it also belongs to the bone marrow. And finally, the bone marrow, CML, chronic myeloid leukemia, and chronic lymphatic, not chronic myeloid, chronic myeloid leukemia, I will talk in the this thing, myeloproliferative disorder section, but acute myeloid leukemia and chronic lymphatic leukemia, and followed by the bleeding disorder. So coming up to myeloproliferative means a proliferation. Lot of cells are being formed because there is something wrong with the controlling mechanism of the proliferation. The controlling mechanism is what's called this thing, Janus K2 gene. Janus K2 gene is a kind of this one kinase. Kinase, the signal molecules. Many of the old practitioners wouldn't know what it is. You have to find out what is this kinases and signal molecules and things like that. A lot of things in this thing. New technology has gone into understanding myeloproliferative disorders and blood disorders. The genetic studies, especially what's called this fish is fluorescent. This thing fluorescent in situ um, chromosomal this one study. What they do is they use an immunoprobe using a fluorescent this thing, DNA molecule, fluorescent DNA molecule. And then they go into a point where they can insert this thing, and it will be tagged. So that will find out where the gene segment which you want to find is there. It's called FISH technology. Then there is another thing called flow cytometry. Flow cytometry studies the nature of the cells, how the cells are, what's the size, what it contains, and things like that. You can actually differentiate between the cells. There is between the cells, because this actually studies each cell in a small whole column of cells, which is taken in a beaker, taken through the neck, the small part of the beaker, the pipette, one cell at a time, and this thing, a laser put through it, and they see the diffraction of it. Sometimes fluorescence is added, so you study it thoroughly, and that's called flow cytometry. Really fascinating study. Then there are so many like that. Then cytogenetics studies, many are there. Not only the old karyotyping and all those things. So in passing in, when we get an opportunity to talk, then cluster CD, cluster differentiation. That is using monoclonal antibodies. You study the antigenic properties of cells. That's called cluster differentiation, CD studies. Actually, CDs, there are more than 300 CDs, cluster differentiating antigens on blood cells and other cells. And the common hematopoietic cell is called CD45, and the B cell is CD19, and the T cell is CD3. I like that. Every cell has got a number is there. Everybody knows what CD, but nobody knows what it's cluster differentiation, antigen study. So that's about it. So myeloproliferative disorder happens because there is a defect in the Janus K2 gene. The Janus means it is a to and fro kind of some messenger molecule. Janus. That's why it's called Janus. Janus is a Roman god with two faces. Janus gate molecule. So what happens is the signaling for the proliferation is turned on all the time. So it goes on proliferating. That's how the myeloproliferation is. What I mean by myeloproliferation, one is what is called polycythemia. Polycythemia includes erythrocytes, WBCs, platelets, and several other things also. And but that's polycythemia. And then I take each one and try to finish it. Polycythemia. So the symptoms will be you have a lot of cells in the blood, so there will be hyper viscosity. You can get what is called erythromelalgia, and erythromelalgia is mostly seen in people having what's called essential thrombocythemia. That is, only platelets are increased. That's a related condition. But actually, you can differentiate between essential thrombocythemia and thrombocythemia along with polycythemia by certain cellular chemistry. We can differentiate. Okay, so it produces this thing, then it produces several other things. In the patient, it becomes very tired, and then you will not have life. So that's polycythemia. So what you do is essentially there is this a lot of there is defined as 2 grams hemoglobin more than the usual, and the platelet count is more than the 6 lakhs at least. It used to be 6 lakhs. Now it is, they have brought it down to 4.5. It's according to WHO. Then they're saying so. So these are some of the symptoms. I'm sure you would have come across. It's not that uncommon. By the way, all these things I'm talking about is not really that common. It is about 10, 15 per lakh, or 4 to 10 per lakh, except a few like multiple myeloma, which may be a little more, like maybe in the hundreds per lakh. So it's not that common, but I'm talking about it. For one thing, you come across it occasionally. Another thing is for the purpose of finishing this thing. And also, it may be interesting to some people who are interested in studying these things, and maybe appearing for exam and all those things. And that's why I'm telling you about this. So polycythemia, the essential treatment is you do a phlebotomy all the time, and bring down the RBC value below 40% of the PCV, packed cell volume. Packed cell volume or hematocrit below 40%. You have to bring. Then you bring down the platelet count also to correspondingly to around by essentially by giving blood, donating blood, giving blood to the blood forum. Then if we have clotting problem, the things like that, you have to give aspirin. Aspirin is also part of the treatment. Aspirin is always given along with this ingredient donor. So that should take care of many cases, but some cases may not respond. They still have thrombocythemia. In that case, you add a drug called this hydroxyurea. So that is the main treatment: hydroxyurea, phlebotomies, and aspirin. And essential thrombocythemia, main treatment is again the same, giving aspirin. And they can give hydroxyurea also, same thing. Then another myeloproliferative disorder is what's called chronic myeloid leukemia. Chronic myeloid leukemia is the one which the so-called Philadelphia chromosome. In the Philadelphia chromosome, they have again the proliferation factor. Apart from the Janus K2, they have what's called this one an ABL-BR this balanced thing, gene gene translocation, some 13 to 17 gene, I think. And so this thing tyrosine kinase inhibition is not there. It is it is going on, and so the lymphoid cells start multiplying, um, and what's the reason all these things go on? They have this. These are genetic mutations, but they need not be congenital mutations. They can be acquired. What's called epigenetic. So it may be environmental, maybe because of chemotherapy, because of the insecticides, because of animal proteins and fats. That's also supposed to cause these things. Some epigenetic genetic defects in the gene, which signals for the cells to go on multiplying. These are not really malignancy, but they are classified as neoplasms. Many of them can turn into malignancy, like they go into chronic myeloid leukemia. They can this one, yeah, they can go into chronic myeloid leukemia, acute myeloid leukemia also. Some of them. That's it. And included in this also is chronic myeloid leukemia, CML. CML is the one I'm just talking about. The treatment for CML is like cancer, but it's a chronic condition. If it's not symptomatic, you can live with it for some time. But when it becomes produces a lot of blast cells in the peripheral smear, and then you have a lot of symptoms, then you have to treat it, and it is treated by a tyrosine kinase inhibitor. uh, it's a monoclonal antibody. This is the imatinib, monoclonal antibody. That actually these are new treatments. This monoclonal antibody, no, this no, sorry, this is not a monoclonal antibody. This imatinib is just a inhibitor of tyrosine kinase. It's an inhibitor. It's a chemical, but it's a good chemical in the sense that it doesn't produce as much derangement in immunity of the person being treated. It's actually good chemical compared to some of the earlier chemotherapeutic drugs. So imatinib is the drug for chronic myeloid leukemia. Then we have another thing called myelofibrosis. So in myelofibrosis has relationship with this one, megakaryocytes. Megakaryocytes are precursors of platelets. So megakaryocytes signaling supposed to cause more fibrosis in the bone marrow. So something is going wrong with the megakaryocytes. That's why the signaling is going wrong. That's why fibrosis takes place. So in fact, many erythrocythemia can degenerate into myelofibrosis. So myelofibrosis is one notch up this condition in the pathology scale, because it is it is more severe than the rest of which I have said, like polycythemia and chronic myeloid leukemia and all those things. But this one, myelofibrosis, fibrosis of the bone marrow. So it's a bone marrow failure. Again, bone marrow you have to replace by bone marrow this one transplant. There is no other treatment. Then these are the myeloproliferative conditions: CML, myelofibrosis. Myelofibrosis is the last of the spectrum. So all these can go into even polycythemia, essential thrombocythemia, chronic myeloid leukemia. All these can go into or degenerate into myelofibrosis. So the treatment part of that also is there. We have finished that one. And going on to multiple myeloma. Multiple myeloma is a very interesting tumor. It's actually tumor, So it's a bone tumor of the plasma cells in the bone marrow, clonal proliferation of the plasma cells. And the plasmas generally make antibodies. This also makes antibodies, but they make some defective antibodies called M1 protein. If you do a serum electrophoresis, generally what you get is first there is a small wave of the albumin. Then you have beta 1 microglobulin, beta 2 microglobulin, then gamma globulin, like that. Here that's a one spike albumin, beta 1 microglobulin, beta 2 microglobulin, and a longer spike, this one gamma globulin. this one they have got what's called M1 spike or M2 spike. That's a bigger spike. The spike means it is an amount of the quantum of immunoglobulin produced in the serum, seen in the serum. So it's actually a paraproteinemia, and they actually before it becomes multiple myeloma, you can have what's called gamma monoclonal gammopathy of unknown etiology or unknown significance. So actually, monoclonal gammopathy of unknown significance is more common than multiple myeloma when you do an electrophoresis. Because if you suspect that, you have to do an electrophoresis. That's the earliest finding for the multiple myeloma. So if you see monoclonal gammopathy of unknown significance, what you have to do is follow him up every year, because every year they degenerate into, some of them go into become, there is maybe 1%, 2% will become full blown multiple myeloma. So multiple myeloma, it produces bone, it invades the bone. Marrow is the bone, so it invades the marrow, then it invades the bone. It invades the bone by a mechanism called the osteoclastic stimulation. It upregulates a protein called RANKL, RANKL is full form. I don't remember what the full form. The same thing which is involved in the thing osteoarthritis also, the knee joint and all those things. So RANKL protein, and then it produces osteoclast. It upregulates the osteoclasts. Osteoclast goes astray, and it goes on producing osteoclast factor, which produces osteoporosis, and they will have punched out lesions in the bone, like small holes, punched out holes, and they can be seen in the flat bones like the scalp or the vertebra and wherever, even this one, the axial skeleton also you can see it. So main thing they present as bone pain. Then again hyperviscosity because of the gamma globulinemia. Then they can present with systemic symptoms like fever, tiredness. Tiredness is one feature. Anemia, all these things. Generally, early stage of multiple myeloma, you can diagnose with anemia, then monoclonal gammopathy in the serum. Before the real bone changes and the kidney failure happens, because of the thing gamma globulinemia, the monoclonal proteins in the serum, it goes and blocks the renal tubules, and that's not exactly the pathology. There are so many other things involved. But anyway, the end result can be a renal failure. Many of them end up in dialysis. Many of them present with secondary fracture of the bones. Spine, hip, this one, humerus, and wherever. So these are the clinical features, and you have to make a prognostication. Prognostication mainly dependent upon the production of beta 2 microglobulin, and also and this one albumin. See, if the beta 2 microglobulin level is less than 4.5, more than 4.5, and the albumin level is more than 2 or 3, then it is stage 1, in the sense that you can live about 5 years even without treatment. But if the beta 2 microglobulin level is goes down less than 4.5, and that is milligram per dl, and the albumin level goes below 2 milligram per dl, then you have a second stage. The longevity is less than 40 months. So maybe a little more than 2.5 years, like that. So according to that, you have to treat him. So main treatment is what is called MPT regimen: melphalan, prednisolone, and thalidomide. These are harmless chemicals, I think. I don't know about melphalan. prednisolone, thalidomide, not that drastic. So amphotericin will give good result in many cases. In cases which do not respond to this, then you have to give, ultimately you will have to give him stem, when once the bone marrow is failed, you have to give him bone marrow transplant, allogenic bone marrow stem cell transplant. Then this is about the diagnosis, treatment, and management of multiple myeloma. Then coming to chronic myeloid, I don't know, this one, acute myeloid leukemia. This is the end result of many of the conditions like myelodysplasia, then even some other myeloproliferate disorders. It can degenerate into acute myeloid leukemia with blast cells, more than 20% blast cells in the marrow. And the treatment is generally by what's called, the donorubicin, doxorubicin, that group of chemicals. That is called some anthracyclines, I think. Anthracycline group of drugs. Then then chronic, that about finishes the this thing, the leukemias, and of course chronic lymphatic leukemia I will talk about after the lymphoma, because it is almost same like because they can also present with lymph node swelling, chronic lymphatic swelling. So lymphoma is a group which is a group known as Hodgkin's and non-Hodgkin's. But Hodgkin's lymphoma is less than 15%. When you say lymphoma, he suffers from lymphoma. What you mean is B cell lymphoma. B cell lymphoma, and one group is that the aggressive lymphoma. That's called this one diffuse B cell lymphoma. This diffuse. There are two types of lymphoma. One is called aggressive lymphoma. Aggressive lymphoma is always diffuse B cell lymphoma, and the indolent means sleepy. Indolent lymphoma. Indolent lymphoma is the follicular lymphoma. It refers to the germinal center follicle. Only it is not diffuse. Follicular lymphoma. Then in the follicular lymphoma itself, there is another group called mantle cell lymphoma, mantle zone or mantle cell lymphoma, which is a little bit more aggressive, like diffuse B cell lymphoma. Diffuse B cell lymphoma, they will have saying most of them will have. If you suspect the lymphoma by biopsy, get a diagnosis, then you have to do a bone marrow. In all these cases, you have to do a bone marrow, because to find a bone marrow means metastasis. Both for Hodgkin's and non-Hodgkin's. Bone marrow, lymphoma cells are present, blast cells are present means metastasis. So accordingly, your chemotherapy regimen and all this will change. Main treatment for B cell lymphoma diffuse gives good result. If you give the old what's called the CHOP regimen, CHOP regimen, that is the CHOP is cyto. This one endoxine, that chemical name C, starts with C. Then hydroxy, this one doxorubicin, that anthracycline group, that is H, and O is oncovin or vincristine, and P is prednisolone, CHOP regimen. So that's our regimen. About 40% respond to that, but nowadays you have to give in cases which fails, especially in old people, they will have more failure. The older you go, more failure. So in such cases, you have to give what is called a monoclonal monoclonal antibody to CD19. That is the B cell. The prototypical B cell is CD19. So CD19, its name is the what is that? Rutimab, Rituximab, not Rutimab, Rituximab. How you remember is actually it's also an anti-rheumatic. So actually, RE is there. That's a Rituximab. So rituximab is the main treatment for all these things. The B cell neoplasms and B cell whatever. Rituximab. That is the treatment for the thing. And but at the end of the day, in old people, the 2 year survival is not that high. But young people, they have good survival with rituximab and CHOP regimen. Rituximab CHOP regimen, that is a treatment. Then coming to Hodgkin lymphoma. So this finishes 90% lymphoma. The internal lymphomas I just finish up. Internal lymphomas, I told you the follicular, it's called follicular lymphoma, but they are indolent, so you can wait and till the symptoms are produced. And if they become, if any chance of them getting aggressive, like a lot of blast cells in the bone marrow, then you have to give the treatment, chemotherapy, and with rituximab, you can give. Then there is another group of indolent lymphomas called marginal zone lymphomas. Marginal means it's around the germinal center. The follicular germinal center, marginal is around that. Actually, between marginal and follicular is the mantle cell lymphoma, which I said can be more aggressive. So this marginal zone lymphomas are indolent lymphomas, and they are actually there's something called a MALT, the mucosal associated lymphoid tissue. It is connected with this one, what is that? This one, peptic ulcer virus. And you have to give that therapy for that. The antibiotic that therapy is triple therapy for Helicobacter. So it's connected to the Helicobacter pylori virus, not virus, bacteria. Helicobacter pylori bacteria, but it is connected to another virus also. There is another thing called splenic zone lymphoma. Splenic zone seen in the spleen, that area. That is, spleen is also a lymphoid organ. So spleen is a lymphoid organ for Hodgkin's lymphoma, but it's not a lymphoid organ for non-Hodgkin's lymphoma. If non-Hodgkin's lymphoma invades spleen, that means it's a metastasis. That's the difference is there. That is more theoretical. I mean, it is like for your entrance people and all those things. So this one, the splenic zone lymphoma, is associated with the hepatitis C virus. So you can give hepatitis C virus treatment, and plus splenectomy for that condition. That will give you a cure actually. Yeah, I think so. Yeah, these are specialized areas. Not a specialist in this, but this is general information, but may be useful to some people. That's why I'm saying. Then this one, then along with that, lymphomas, we will take up chronic lymphatic leukemia. Same as lymphoma, they present with the lymph node swelling. Then a lot of round cells in the peripheral smear, and they can have same symptoms like bleeding and hepatomegaly. I mean, not hepatomegaly, hepatosplenic, but mainly splenomegaly, and things like that. And the management is actually with a drug called I think fludarabine. Fludarabine, I don't know what class of drug it is. It's probably an alkylating agent, alkylating drug. So it's a drastic drug. It doesn't have monoclonal antibody treatment. It's chronic myeloid leukemia. But in only symptomatic cases you have to treat. Otherwise, for 10 years they will go intolerant, very intolerant. Chronic lymphatic leukemia. Then there's about Hodgkin's lymphoma. Hodgkin's lymphoma radiotherapy gives good results. especially in bulky disease. Bulky disease means a lot of mediastinal lymphadenopathy seen in younger people. Give this thing, actually it melts to radiotherapy. So radiotherapy is good treatment for Hodgkin's lymphoma. Then the treatment for Hodgkin's, again, did I say ABVD, adriamycin, bleomycin, vincristine. I think I forgot to say that. ABVD is it's not CHOP regimen for this one Hodgkin's lymphoma. It's ABVD, adriamycin, bleomycin, vincristine, and doxorubicin. I think no, not doxorubicin, dacarbazine. Not doxorubicin. D is not doxorubicin, dacarbazine. In fact, nowhere is doxorubicin D. It's H in the CHOP, hydroxydoxorubicin. So ABVD is the treatment for Hodgkin's lymphoma, and then the chronic lymphatic, I said. Then acute myeloid leukemia, another condition. You see a lot of myeloid blasts in the bone marrow, about 30%, more than 30%. And the treatment is with again drastic chemicals like anthracyclines. I think so. Anthracyclines. Yeah. Then coming to the bleeding disorders in the elderly. Bleeding disorders mainly platelet disorders and bleeding factor disorders. Bleeding factor disorders, the same things which happens in young people, like factor deficiency. Hemophilia can go into old people also, but old people also mainly have platelet defects. That's called purpurus. Purpurus, and also platelet defects. And another platelet defect is what called DIC, diffuse intravascular coagulation. And so they are the platelet defects, and the primary platelet defect is called like ITP, idiopathic thrombocytopenic purpura. Same thing. It's an antigen antibody based thing. So platelet antibodies are there, and it actually it will bring down the number of platelets in the blood, and if it goes down below 10,000 in the blood, it can produce symptoms like bleeding, even intracranial bleeding. So you treat it. And ITP, many of us would be thinking that it's a disease of young. It's not. Actually, ITP incidence goes up as you grow older. I think not many people would know it. Actually, it's a disease of old people. This one, idiopathic thrombocytopenic purpura, and it gives the same, but the treatment is same. You give steroids, then you give immunoglobulin, because immunoglobulin will reduce the splenic consumption of the platelets. Immunoglobulin. Then you give the thing also. Then there's the testosterone drug, Danazol, as a treatment for ITP. So, but more common than ITP for platelet disorder in old people is called secondary thrombocytopenia. Secondary to maybe drugs, or secondary to illness like septicemia, or so many things, but nothing. Main thing, as far as we are concerned, main thing is called heparin related, heparin induced thrombocytopenia, HIT, heparin, even though it's an anticoagulant, it can also produce certain antibodies against induce antibodies against heparin cofactor. Heparin is called heparin cofactor antibody, and heparin is called a heparin cofactor antibody, and it will clog this one. It will join up the platelets and produce small clots. It's something like then it produces bleeding, then produces thrombocytopenia, small clots are formed, so the platelets are consumed. So as a result, there is platelet deficiency. So that's secondary thrombocytopenia. Thrombocytopenia, secondary. Primary is ITP. Secondary is this thing, the platelet defect, the reduced number of platelets because of small clots in the vasculature. There's another interesting condition called thrombotic thrombocytopenic purpura. In thrombotic thrombocytopenic purpura, it is actually acutely produced thrombocytopenia because of, again, the condition because of thrombosis. What happens is there is a clotting factor in the tissue called, actually it's not tissue, it's endothelium, called von Willebrand factor, which has to be cleaved by another protein. Some name is there for the name. That is defective. That's a genetic defect. So, but some things can induce, like the person has some crisis, like he has infection or some drugs are given. Notorious drug is clopidogrel. I don't know many people know about it. Clopidogrel can induce thrombotic thrombocytopenia purpura. A drastic condition, a lot of bleeding, in acute bleeding. So the treatment is, what is the treatment? It's a antibody based thing. So you have to remove that from the serum. So you to do a plasmapheresis. Plasmapheresis, actually not plasma exchange. There is a difference between plasmapheresis and plasma exchange, but it's one of degree. In plasmapheresis, you remove less than 20% of the plasma. Plasma exchange, you have to remove the whole plasma. And if you all these things can be seen in the YouTube. How do they do plasmapheresis? Just like dialysis, but it's not same as dialysis. And then the diffuse intravascular coagulation is another condition. That's because of the clotting mechanism being overwhelmed by the thromboplastin released from something, by infection or sometimes with even dead fetus, so many things. So it's a thromboplastin induced this thing, clotting, and there will be a lot of fibrin degradation products, and that's how you diagnose it, by the fibrin monomer in it, or D-dimer, and fibrinogen level will be low. It's one bleeding condition where the fibrinogen level is really low. But because the mechanism is clotting, in microvascular clotting causes DIC, diffuse intravascular clotting, DIC. But in that, no use giving heparin to it. Anticoagulants are not recommended for it. You replace the factors, that's it, and hope for the best. Okay, good night, thank you. Let's hope for the best. Thank you.